the topic given to me is common pediatric eye disorders. It's a very vast topic. I'll be just giving you an overview of the common eye conditions, which will be of interest to the pediatrician. And if you have any doubts at the end of the talk, you're free to ask me. So let me start with red eye in children. So it's a very concerning sign for the doctor, as well as an alarming, condition for the parent. So most of the time, the child or the parent will bring the child to the pediatrician first. And so it's very important that we should know which is the innocuous condition and which is the most serious condition. So on the left, you can see this is a very diffuse conjunctival congestion. The cornea is clear. This is a simple conjunctivitis. Whereas on the right side, I don't know if it's visible to you. Is the screen visible? Yeah, you can see here there is a corneal lesion and there is pus in the anterior chamber. So this is keratitis with infection of the anterior chamber, and it can even lead on to endophthalmitis if treated, if you don't treat it properly. So the nutshell, what I would like to say is that it could be as simple as a conjunctivitis to a very serious condition known as endophthalmitis. So acute red eye in children needs a very close attentive care. And we will start with the history. What are the salient points in the history that you'd like to know? So initially itself, you ask for any history of trauma or insect bite, which would help you to pinpoint the diagnosis. Ask for any history of drugs, installation of any drugs or accidental installation of any drugs or swimming pool use or contact lens use, which would be the reason for the redness. So specifically ask for vision, or if there is any difficulty in opening the eyes, especially in bright light or any blurry vision. And as pediatrician, you would be very sensitive to systemic features like presence of fever or sore throat or any rashes or joint pain or any other allergic signs. So when you are examining the child, even if it's with a torchlight, gross things can be made out, like the external appearance of the eye. Is there any adnexial problems in the lids? Like, is there any discharge, any scales, any redness, any swelling of the lids, nodules or papules? Or look at the conjunctiva. Is the conjunctiva red? Is there any ballooning of the conjunctiva, which is known as chemosis? Is there any tear or ulceration of the conjunctiva? So coming to the cornea, even with the torchlight, you can make out the normal corneal clarity. So look for the clarity of the cornea, presence of any foreign body or any staining of the cornea with fluorescein sodium. If it is present, you can use that. Look at the anterior chamber. It might be difficult for the pediatrician to assess the anterior chamber details, but presence of any blood or pus in the anterior chamber can be easily made out. So look for presence of any RAPD in case of trauma, and ocular movements and presence of proptosis can also be assessed. If possible, do a fundoscopy and intraocular pressure digitally you can do. So once you take a proper history, then you do a clinical evaluation, you'd be able to come to a conclusion. So conjunctivitis is something which comes to the pediatrician first. So this picture shows you a normal eye, a picture of bacterial conjunctivitis, viral conjunctivitis, allergic conjunctivitis. All of them look the same. So how do we differentiate? So some salient points in the presentation. So bacterial conjunctivitis, the eye will be diffusely red. There will be discharge, which is usually greenish. The lashes will be stuck on, and there may be history of fever, but there may not be always a history of fever. It may be just an isolated conjunctivitis. Whereas a viral conjunctivitis, also there will be diffuse congestion, but the discharge is usually watery. There is usually no purulent discharge in typical viral conjunctivitis. In allergic conjunctivitis also, the discharge is watery. So how do we differentiate? So ask for how the child behaves with the congestion. Does the child keep rubbing the eyes? Is the child always rubbing and touching the eyes and wiping the tears? So if there is constant rubbing of the eyes and increase in the redness, especially after exposure to outdoor activities, more towards evening, it's more in favor of an allergic conjunctivitis, and it's usually bilateral. And ask for any other associated allergic symptoms or signs. Okay. So if you have a child with a painful red eye, it's a good idea to put a drop of topical anesthetic like this case, you can see proparacaine, this is commercially available to relieve the photophobia. Then the child will willfully open the eye and allow you to examine. So in this case, you can see the culprit is a corneal aberration. There is a defect in the corneal epithelium, which is so painful that the child is just not going to open the eyes and allow you. So if you are in a doubt, you can use this strip of fluorescein sodium. It's a very handy tool in your OPD. You can stain the conjunctival sac and the defect will be appearing as greenish in color, and that shows the area of defect. So in this case, this child has multiple staining areas, which is suggestive of a keratitis. Or it could be something like this. This could be something like a foreign body. I don't know if it's visible to you, or is the, these things are obscuring the screen, I'm not sure. So you can see here, there is a, just remove this a bit to the side so that, you can see a foreign body here, which is stuck onto the cornea, which is the reason for the red eye. So remember that if it is painful, it is not usually conjunctivitis. And in unilateral red eye, you have to rule out a foreign body or a lash which is rubbing onto the cornea, or trauma, or dacryocystitis. Don't forget to double invert the lid for a hidden tarsal foreign body, because children we know are notorious to put things into their eyes, nose, mouth. Just like that, they find the conjunctival sac also a very easy place to hide things. So I have had children with, eclairs, wrappers hidden in the fornix, producing chronic conjunctivitis, which is not amenable to treatment. So only when we double inverted the lid, we got this wrapper, and child wanted to hide it from his elder brother, and that was producing chronic conjunctivitis. So be very careful, because children may not be very forthcoming with their history, and you may miss it out. So let's see, what is this condition? Can anybody tell me this? So this is a diffuse conjunctivitis. You can see here, the child has come to you with watery discharge, foreign body sensation. There is a tinge of subconjunctival hemorrhage here. Child had a history of fever, upper respiratory tract infection. And when you examine, there is preauricular lymphadenopathy, multiple family members affected, and that shows it's contagious. So in younger children, this may even, mimic an orbital cellulitis, and pediatrician may think of it as an orbital cellulitis and start IV antibiotics. But this is nothing but viral conjunctivitis, which is usually due to adenoviral infection. In severe cases, there may be pharyngoconjunctival fever or epidemic keratoconjunctivitis, but most of the time it may be an isolated condition with fever and preauricular lymph node enlargement. So the treatment is just supportive and symptomatic treatment. You can give topical lubricants, antibiotics. You can give a prophylactic mild antibiotic like chloramphenicol to take care of secondary bacterial infection. And in certain cases, you may have to start the patient on topical steroids, like if there is severe swelling, severe ballooning of the conjunctiva, or if there is corneal involvement. But most of the time, it will subside with supportive and symptomatic management. And there is no role of topical, antiviral agents in these cases, because adenoviral infection does not respond to the usual antivirals that we have in the market, like acyclovir. But in specific cases like those with HSV or herpes zoster, you may give topical antivirals. Sometimes it could be a molluscum at the lid margin, which may produce a red eye. So it's a key important thing is to look at the lid margin adnexia and the associated features. Okay, what about this condition? You can see here. So here you can see there is, this is an allergic conjunctivitis. You can see there is ballooning of the conjunctiva. Child will come to you with red eye. And I just move this thing here. I'm sorry. Yeah, and you can see there is some, elevated lesions at the limbus, which is known as papillae. And in severe cases, you may get these, papillae, which may be broken down and appearing like cobblestones on the pavement. So this is called as cobblestone papillae, and sometimes they may rub onto the cornea and may produce an ulceration. So these are the various stages of vernal keratoconjunctivitis. So in mild cases, they may respond to topical anti-allergic medications. In severe cases, when there is these limbal elevations and papillae, you may start the patient on topical steroids, And this sort of ulceration definitely needs a very careful treatment from the ophthalmologic point of view. So another condition which is first seen by the pediatrician is ocular discharge, especially in newborns. It could be a neonatal conjunctivitis or ophthalmoneonatorum, or it could be a congenital nasolacrimal duct obstruction. So we are all familiar with the various differentials of neonatal conjunctivitis, especially if it is acute. Within 3 to 4 days, think of gonococcal infection. Within a week, rule out chlamydia. And within 2 weeks, it could be herpes simplex. So they all have systemic manifestations, and a simple prophylaxis of 1 drop of 2.5% povidone iodine into the conjunctival sac is good enough to prevent most of them. It's a cheap and effective treatment. Now, management, all of them will need a systemic management. You're all familiar with the management. I won't go into the detail. Now, another common condition which comes to the pediatrician first is congenital nasolacrimal duct obstruction. So it is usually seen as a watery eye or an ocular discharge in a white eye. The eye is not usually red. So what you can see is that the child will have a tearing eye, and the key sign is ROPLAS positivity. That is, if you press over the lacrimal sac, you will get a regurgitation of fluid. It could be either a clear fluid or purulent or mucoid, depending on the type of secretion. So long-standing cases, you will have secondary dermatitis of the eye, and in some cases, it may exacerbate and become acute dacryocystitis, which is an emergency, which needs IV antibiotics, and sometimes you may have to drain the abscess. And chronic cases also may present with swelling, localized swelling known as dacryoceal, or sometimes it may be present at birth itself when it is called as an amniontocele. So these cases, the good thing about the congenital NLD obstruction is that most of them will resolve by 1 year by itself. So no aggressive management is required unless it is in this condition. You have to tell the patient, and you have to tell them and show them the proper way to treat it, which is called as Krigler's hydrostatic sac massage. This is a video which shows you the correct way to massage the sac. So you can see how the massage is done from up to down in the direction of the nasolacrimal duct. So this is a correct way to massage the lacrimal sac. So when you massage, you produce a negative suction force in the NLD, which kind of opens up the imperforate valve, which is there below. So any discharge which is present after 1 year of age, there is an indication for putting a probe and breaking the block. And if that doesn't work, you have to go for a surgery, which is a dacryocysto-rhinostomy. In the meanwhile, if there is some amount of discharge, you can treat the patient with broad spectrum topical antibiotics, but none of them will need it for more than 10 days. The key factor would be showing them and demonstrating how to do a good sac massage. Okay, another condition which is seen by the pediatrician first would be this, a cloudy and enlarged cornea, which is a sign of infantile glaucoma. So you can see the cornea is definitely enlarged. It is cloudy, and this is what is typically known as a ophthalmic eye. So this needs an urgent referral because a raised intraocular pressure, if left untreated, can produce optic neuropathy and permanent visual damage in the child. So an examination and anesthesia to confirm the raised IOP and urgent surgical correction or surgical management in the form of a trabeculotomy with trabeculostomy will help to clear the cornea, even though the enlargement of the cornea may persist. But the child will have vision if it is done initially itself. So ocular trauma is another condition which presents with red eye. I've already explained. So you can see this is a subconjunctival hemorrhage, a corneal aberration, a foreign body, and blood in the anterior chamber, which is known as hyphema. So another condition which may present with red eye, and especially if it's localized to the lid margins with scales, this is known as blepharitis. Now, it could be something as simple as squamous blepharitis, which is similar to seborrheic dermatitis, or it could be an ulcerative blepharitis, or it could be sometimes something very rare but not unseen in our part of country called as Thiruvananthapuram palpebrum, when you have lice and nits sticking onto the lashes. Especially, it's the pubic lice which produces Thiruvananthapuram palpebrum, and it is seen in patients who have who are not hygienic enough or who may have this pubic lice. So the treatment would be to epilate the lashes one by one and to suffocate the lice with some sort of eye ointment and mechanically remove them. So this required, it's an STD, so you have to treat all the contacts. Okay, moving on from red eye to swelling, so the eye, so along with redness. So this is a very common condition. So this is a stye or an external hordeolum. You can see here the lid margin is swollen up and there is pus pointing. So the treatment would be to do a hot fomentation twice daily with a broad spectrum topical antibiotic eye drops and an antibiotic eye ointment. But in very small children, especially infants, you have to look for any signs of preseptal cellulitis, because if you don't take care, it may soon become preseptal and become orbital cellulitis. So if you see any preseptal edema, it's a good idea to start all antibiotics. And if it's not responding within 24 hours, it's better to start IV antibiotics. So be very careful in very small children because it can progress to orbital cellulitis within hours. So sometimes it can be an internal stye, which is known as hordeolum internum. And this also often responds very well to topical antibiotics, but in cases with preseptal or preseptal swelling or threat of orbital, spread, you should start the patient on systemic antibiotics. If it is not responding and becoming a glazion, you will have to do an incision and curettage. So these are some rare conditions which may present with red eye. I won't go into detail, but these are, definitely alarming enough for you to send a referral to the ophthalmologist. Okay, now let's come to something more common, which is the squint. So here you can see most often squint is taken up, it's often thought of as a very common condition with a cosmetic implications only. But what I would like to say is that squint can be sometimes the warning sign of more dangerous conditions, like, a retinoblastoma may present as a squint, a cataract may present as a squint, or, anything which is causing sensory deprivation in the child can also present as a squint. So don't take squint lightly, and any child who's having a deviated eye, which is persistent, should be referred, especially after 3 months of age. So here you can see, you can look at the corneal light reflex. You can see this reflex is outside because the eye is deviated inside. So this is an esotropia. And here the child is having an exotropia and the reflex is deviated inside. So if you have a child with constantly deviated eye, you have to suspect lazy eye due to constant decreased vision in that eye. So sometimes it could be pseudo-esotropia. Most of the time I get these pseudo-esotropes to me because they may have a flat nasal bridge or prominent epicanthic folds. But nevertheless, it's very important to refer the patient if you suspect a squint, because it could be something as simple as a refractive error or a muscle problem, or something more dangerous like a underlying retinoblastoma. So if you pinch the epicanthic folds, you can see the sclera very well and rule out the pseudo-esotropia. But make sure you follow up these patients, because if you don't follow them up, some of them can actually develop into true esotropia. I've had children with pseudo-esotropia going back again, examining them, developing true esotropia. So it's a good idea to keep them under regular follow-up, even if you think it is a pseudo-esotropia. So all squints don't need surgery. Some of them just needs a glass correction. So like this child with esotropia did very well with hypermetropic correction, you can see here. And this child with myopia did extremely well with myopic correction. So all squints don't need surgery, whereas some squints do need surgery, and they do well when you do the correct surgery at the correct age. Because for them, it's not just a cosmetic improvement. There is also a functional advantage of getting their binocular vision back, which will help in their coordination and also in their confidence. So white reflex in the eye of a child is a very alarming condition, and retinoblastoma is something which we rule out first. But most of the time, it may be a cataract, or it could be a small microphthalmic eye with vascularized opacity like a persistent hyperplastic primary vitreous. or it could be something like Coats disease, or sometimes it could be an untreated ROP, which I don't see nowadays because we're all very much aware of the ROP screening guidelines, and the pediatricians are very good at that. They are very aware of the ROP guidelines. So a word about the pediatric cataract. In spite of the increased awareness, cataract still remains the most important, one of the important causes of preventable blindness in children. And it could be isolated or part of a systemic condition. It could be unilateral or bilateral. It could be idiopathic or secondary to others. So what you have to remember is that the smaller the child with cataract, greater will be the threat of lazy eye or amblyopia to the child. And so you have to refer the patient. So do all cataracts need surgery? No. If it's not, dense enough, how do we assess that? So if it's a totally dense cataract, it definitely needs surgery. So any visual, any lenticular opacity which is within 3 millimeters of the visual axis definitely needs to be removed. And when do we do the surgery? So if it's a unilateral cataract, it has to be removed within 4 to 6 weeks of age if there is no contraindication for general anesthesia. If it's bilateral, it should be done within the 10 weeks of birth with 1 to 2 weeks of gap between the two surgeries. So this is a picture of a child with cataract pre-op and after surgery. The visual axis is clear, you can see here. So a word about ROP. The ROP awareness is good, and we don't see any bad cases nowadays. But once again, emphasizing the need for early screening, especially if the child has low birth weight or it's stormy neonatal period, so that they don't end up like this, and when we cannot do anything for their vision. So as pediatricians, how do you pick up this white reflex and reflex anomalies? So what the American Academy of Pediatrics and Pediatric Ophthalmology recommends is see red or assess the red reflex. So if you throw the light of a direct ophthalmoscope at 1 meter into an infant's or a child's eye, you should be able to see both the pupils illuminated equally well. So if you see any abnormality in the reflex, it is considered abnormal and the child has to be referred. So what they say is see red. If both reflexes are equally red, it's fine. But if one reflex is brighter than the other or duller than the other, it warrants a referral to the ophthalmologist. So if there is a squint or refractive error, that eye will appear to be having a brighter reflex than the other eye. So this is what they recommend as see red. So refractive errors is again very common, and most of the children are born hypermetropic. Some of them may be myopic at birth, and these children need earlier follow-ups and examinations. Some children are prone to develop refractive errors more than the other, especially preterm infants, especially those with ROP, and especially if they've had a laser treatment for ROP, will definitely develop myopia at some point of time. Astigmatism is quite common in children, but it usually, sort of settles down by 2 years. So that brings us to the question about amblyopia and vision screening in children. So in spite of all this awareness, amblyopia, 50% of amblyopic cases still go undetected till 5 years. And because of that, we have to follow these guidelines, which have been set down by American Academy of Pediatric Ophthalmology and Strabismus, which says that any child who has any of these risk factors definitely needs a referral to the ophthalmologist. So if there is a difference in the refraction between two eyes of more than 1.5 diopters, if there is a manifest squint, if there is a hypermetropia of more than 3.5 diopters, a myopia of more than 3 diopters, any opacity which is obscuring the visual axis, any astigmatism which is more than 1.5 diopters in the regular meridian or more than 1 in the oblique axis, any ptosis which is less than 1 millimeters of margin reflex distance, so any deviation from the visual acuity which is appropriate for that age needs a referral to the ophthalmologist. So when should a child have the eye examination? This is a very common question which a lot of parents ask me. So what I say is that the examination of the child starts from the birth itself. So your pediatrician would be checking your eyes, the child's eyes, right from the time the child is born, and then in the newborn period itself, at all well-child visits. And then before starting school, it's a good idea to have an ophthalmic examination So this is all in case of a child who does not have any complaints, and thereafter a yearly examination is advisable. And you can have a visual acuity measurement at the earliest possible age that's practical. So usually what I say is before starting preschool, that's usually at 3 years of age or before. So if the child is symptomatic or having any risk factors, risk factors for eye involvement or systemic conditions or stormy neonatal period or ROP, these children need early referral. So these would be the warning signs of poor vision, like absence of social smile, not responding to visual stimuli, or bumping into objects, poking eyes, or a closure of one eye in bright light, presence of an abnormal red reflex or a white reflex, holding books close to face, or poor scholastic performance. So all these signs are signs of poor vision, and the child needs an ophthalmic examination. So another condition which is commonly seen is droopy eyes or ptosis. So it could be bilateral or it could be unilateral. So looking at this, we can see that there is no obscuration of the visual axis. So does this child need a referral to the ophthalmologist? Yes, this child also needs a referral because this ptosis can sometimes produce astigmatism by pressing onto the cornea. And if the astigmatism is more in this eye than the other eye, it can produce an anisometropia or a difference in power between the two eyes and can produce a lazy eye in this eye. So this child also needs a referral to the ophthalmologist for the taking care of any amblyopia if it is present. If it is associated with more dangerous signs like this, definitely these children will be referred to the ophthalmologist. And we often treat these children in collaboration with the pediatrician, like the capillary hemangioma of infancy. Oral propranolol does wonders, and often the dosing and the monitoring is done with the help of the pediatrician. Orbital cellulitis needs IV antibiotics. Again, the child may have to be admitted in an ICU. And more dangerous conditions like these are also presenting to us sometimes with ptosis and troptosis. So moving on from ptosis and troptosis to cortical visual impairment. So this is another area which in which the child has the pediatrician and the ophthalmologist play a very important role in rehabilitation, because this is one of the #1 causes of visual impairment in children in the developed world. And even in India, we see a lot of cases of cortical visual impairment. So here they have some risk factors, and they may have structural abnormalities in the brain, especially in the visual processing areas. And we need a very patient follow-up with these children. So if the child, what I usually see is that most of the children improve with time. And in infants, we can do serial BEPs to follow them up. And presence of an intact visually evoked potential is a good sign that these children usually may improve with time. And you can advise visual stimulation exercises along with their physiotherapy. And depending on the damage to the brain, these children show various levels of improvement with time. Another condition is called as delayed visual maturation. So what is delayed visual maturation? This just means that there is a delay in visual maturation, and the children may be unresponsive in early infancy. There is a delay in visual milestones with no apparent ocular abnormality, but they spontaneously improve to normalcy by 6 months of age. So often if you take a history, you will get some history of prematurity or some seizures or systemic diseases or any precipitating factor in the antenatal period. And ophthalmic evaluation, initially the child may be unresponsive to the usual examination techniques, and everything may appear normal in the examination. Structural changes may not be there, but they usually improve. A follow-up is all what is required, and they usually improve by 6 months of age. And people think that a delayed cortical myelination and maturation is the cause for this, or sometimes there could be some structural defects without any permanent damage. So now moving on to systemic associations. So sometimes you may get cases in which there is, systemic associations and systemic implications in the eye also. Like, for example, this child was came to us was brought by her parents with complaints of bilateral reddish black eyes and sudden onset of squinting. So on careful history taking, they gave a history of child falling down from the bed about 2 to 3 days back, and she's after that she had a little irritable behavior. So when we examined her, we found that she had bilateral sixth nerve palsy, which was a reason for her esotropia here, and she had this bilateral periorbital ecchymosis. So fundus examination was suggestive of bilateral papilledema. So what this child actually had was a basal skull fracture, which was causing this panda sign or raccoon eyes. And this child needs urgent anti-edema measures to lower the ICT. So this is a case which tells you the importance of correlating the ophthalmic findings with the systemic findings. So sometimes the red eye may come with other infections, like this child. Child is having conjunctivitis and inflamed tongue and mouth and rashes on the body. So this could be any exanthematous fever, or more sometimes it could be specific conditions like Kawasaki's disease. So it's very important to see the child as a whole before we make the diagnosis of anything, and we may have to have a conjoint effort by the pediatrician and ophthalmologist in coming to the diagnosis. So this is another interesting case of a child who was referred to squint surgery to me. So you can see he's got squinting in the eye. The parents said since last 5 years. He was about 10 years when he presented to us, and he was advised for squint surgery. So you can see he's got an esotropia in the right eye. And parents brought out this family album. If you look at the picture, you can see he was quite straight at birth. Even during his early infancy, he was fine. But then at 5 years of age, you can see that he slowly started to squint, and the squint increased. So it was at 5 years, which the mother said he suddenly started to squint. So there was no history of any trauma. There was no refractive error. Optic nerves, when we examined the fundus, we thought there was some amount of pallor, and the OCT of the optic nerve had also showed some RNFL thinning. But apart from that, there was nothing. The ocular movements were full. But something was not right, and this sudden onset of esotropia was a red flag which prompted us to image him. And that's when we saw that he had these hyperintense, predominantly white matter lesions, which was involving the midbrain, and which was extending even almost up to the optic tract. So this was diagnosed as a glioma, case of glioma with neurofibromatosis 1. And this child is on follow-up because the glioma is slow growing. We have decided to follow him up, and he's fine right now, even though the squint is persisting, and he's been advised squint surgery to correct the squint. But this would have been missed had we not done an imaging, because of the sudden onset of squint. That was a red flag in his history. So last but not the least, a word about digital eye strain in children. So in this era of pandemic, so the digital eye strain is the new disorder which is coming up not just in children but also in adults. So it is defined as a discomfort which is occurring from staring at the screen for too long, which may manifest as blurry vision or tired eyes or watery eyes or stinging eyes, or even sometimes it could be just eye ache or headache. So a few tips to avoid this eye strain would be to follow these recommendations. One is to keep the device at the correct distance, ideally at an arm's length, and if you're using a tab or a mobile, slightly below your line of vision, so that your posture is maintained, especially of your neck and back, and the lighting should be good and ambient. Remember the 20-20-20 rule, that is to take a break from the screen every 20 minutes, set a timer if you need one, and look at least 20 feet away from the screen for at least 20 seconds. So that might be a little too much, but at least after every half an hour, we could take a break. Adjust the brightness and contrast of your screen so that you're comfortable in your vision. So these are some recommendations, and if that doesn't work for you, you can consult your ophthalmologist for some lubricating drops to keep your eyes lubricated. So to conclude, I'd like to say that visual disorders may have a dramatic impact on child's behavioral and psychosocial environment. So in spite of advanced pediatric care, visual morbidity continues to be a serious concern, And the need of the hour is the teamwork. And thank you for your patient hearing.
Unmute here. Thank you, Neena. That was a very informative talk with pictures and very comprehensive indeed. Within this half an hour, you have told almost all the problems which we see and which is actually needed as a discussion. And there are a few queries in the chat box. The first one is you have been discussing about ROPLAS. What is ROPLAS?
ROPLAS stands for regurgitation over pressure over lacrimal sac. It's a short form.
Okay.
But what is, so you saw the video, no? When we were massaging. So when you apply pressure over the lacrimal sac area, if you just press there, whatever is collected inside the lacrimal sac will come out, regurgitate. So that is the diagnostic sign of a NLD obstruction, nasolacrimal duct obstruction. So if you are able to demonstrate this sign, you can diagnose that the child is having a nasolacrimal duct obstruction, and that is the reason for the watering.
Okay. Now another doubt is regarding the STI, the topical application of antibiotics. Is it useful?
Yes, it all depends on when you see the patient. Suppose the patient comes to you very early. If it's an acute hordeolum, it's painful for the patient. And it's usually due to a staphylococcal infection. So I usually give a topical broad spectrum antibiotic like a moxifloxacin 6 times for 10 days along with an antibiotic. And also aggressively tell the parents to do hot fomentation. So if it's an externum and if there is a pus pointing, if it breaks, it drains and the swelling is relieved. But if it's an internum and, again, it will subside. Usually it will subside. But you have to be very careful in smaller children, in infants. Infants, I usually call them within 48 hours. So I usually tell the mother to monitor the child's swelling for 24 hours. If there is any threat of preceptor swelling, I usually start the patient on oral antibiotics. Like my drug of choice is an Ampiclox combination, but augmentin will also do fine. But if it's a very small child, a 1-month-old baby, I even sometimes consult my pediatrician friends whether we should go for an IV antibiotic if there is a threat of orbital spread.
And the next thing is whether drops are useful or ointment is useful regarding antibiotic.
Yeah, that's what. If it's an internum, drops are useful. If it's an externum, if it is on the external aspect of the eye with pus pointing, an antibiotic would be better.
Okay, thank you. And the next question is regarding treatment for neonatal conjunctivitis.
Yeah, neonatal conjunctivitis, again, I told you, you have to see the time of onset. If it is within 2 to 3 days, you have to rule out gonococcal infection. It may not be very common now, but again, that should be ruled out first. If it is within, a little later than that, chlamydia is what is more common now. And if it's within 2 weeks, HSV is suspected. But a simple installation of 2.5% povidone, which is betadine drops 2.5% into the conjunctival sac, may be preventive enough to prevent this condition in most of the cases. But definitely, if it is not subsiding with a broad spectrum antibiotic, once it is started, you have to think of systemic therapy, and you have to take scrapings and look for any microbiology, which will help you in starting the systemic therapy.
Okay. Another doubt is regarding.
But what we usually see is that most of the neonatal conjunctivitis is usually responds to a broad spectrum antibiotic.
Do you see cases of vitamin A deficiency? Is it, do you see commonly?
I don't see much. I don't see, probably because
of the program.
of the good, probably their vitamin D supplementation is also going on. No? So I don't see much of that. But when I was working in Kolkata, I did see, a lot of cases of vitamin D deficiency, even night blindness also. But in Kerala, I have not seen.
Okay. Sir, Santosh sir.
Happy to see you, Neena.
Thank you, sir.
My one or two questions. One, you said about the 20 feet. That 20 feet is not practical when you are working with the computer, especially with this.
Yeah, it's not I
So, I mean, is it that the monitors have got some special screen or something built in? Because monitors are actually expensive as compared to TV. So, is it actually? I do not know the technical details, but is it that there is an additional protection for close viewing in monitor? I do not know. I was just wondering when you said like that, because in monitor you'll have to go on for hours together. Yes, Neena, please.
Yes, sir. So the latest laptops do have an anti-glare screen, so you don't need to do anything with your screen. But what is more important is if you have a lot of children who are using mobiles for their online classes, especially not the higher end phones, the Android versions with blue light. So this blue light is not very good for the eye, and that's why if you're using the mobile phone for a long time, it's a good idea to put a blue filter. In your spectacles so that there is protection. But most of the iPhones and even the latest and the laptops will have a good anti-glare screen, and the iPhones don't. I mean, the blue filter is not required. So the desktops, if it's an old version, it might be a good idea to put an anti-glare filter. But the latest laptops and the most of the new ones don't need this because they already have an inbuilt anti-glare screen. This is what is my understanding of the thing. I'm not a technical person, but this is my understanding.
Okay. In case of vitreous hemorrhage, spontaneous vitreous hemorrhage, which is say, for example, coming up to 50%, then what is the trigger point where you'll go for laser or wait for spontaneous resolution? And what is the role of steroids in this?
So again, it depends on the cause. Like in a child,
spontaneous.
So most spontaneous means like there could be some underlying cause. You may not be able to see it immediately, but initially we usually advise a conservative management. We ask the patient to lie with pillows so that the hemorrhage drains and the visual axis becomes cleared up. But suppose it's not clearing vitreous hemorrhage, there is a threat of amblyopia. There is a threat of amblyopia to the child because there is visual axis obscuration. So if it is persisting for more than 3 to 4 weeks, there is a serious threat of amblyopia to the child, and the eye may start squinting. So these are some warning signs that you need intervention. Now, if your pedia is clear and there is something, there is a bleeding vessel or there is something which can be lasered, you can go ahead and laser it. But if the media is so hazy that you cannot do any laser treatment, you will have to go for a vitrectomy, which is a surgical removal of the blood. This is what we use.
So after vitrectomy, you use some fluid inside. Huh?
Yes,
I do not know.
Yeah, again, it depends on the cause. So what you see is sometimes it could be traumatic. It usually may not be spontaneous. If there is child is having some systemic conditions, it can be spontaneous. Or it could be a condition called as X-linked retinoschisis, which can produce, vitreous hemorrhage. So whatever it is, we are more concerned with the sensory obscuration amblyopia, which is happening to the child. So if the vitreous hemorrhage is clearing spontaneously, we wait. But if it's not clearing, we have to, we are little more aggressive in children than in adults because of the risk of amblyopia.
Will there be anything like retinal detachment or something happening? So if you wait.
It can be. So it could be just a vitreous hemorrhage. So if there is a vitreous hemorrhage, first thing we do is a B scan, ultrasonography of the eye to see the status of the retina. So if the retina is normal, we wait. But suppose there is a retinal detachment, then there is no point in waiting. Even if you wait, the retina is not going to attach. So that requires immediate surgical management. If it is amenable to surgery, we give a chance.
And recurrent stye also, please. What are the causes and what to do about it?
The recurrent stye, so you have to look at the lid margin for any lid margin disease. So most of the time it could be, some blepharitis. So blepharitis is a very important cause of recurrent stye. So you have to carefully look at the lid margin for any condition which can produce blockage of the tear ducts and produce stye. So I advise good lid scrubs to them. So you can make your own scrub by asking them to take a mug of lukewarm water and put 1 or 2 drops of baby shampoo, or you can buy any ready-made scrubs and ask them to scrub the eyes in the morning, just like you brush your teeth. So these scrubs would make sure that the scales which are there at the lid margin drop off, and the obstruction to the tear ducts does not happen. And you can get antibiotic ointment at bedtime along with the lubricant. Sometimes other conditions like rosacea, or some lid margin disease like molluscum can also present similar to with recurrent stye. If there is a recurrent stye, also look for any hidden refractive errors. So anything which is producing a constant strain to the visual apparatus can also produce a recurrent stye. So we usually do a refraction and dilated refraction and see if the child is having any difficulty in vision, and give appropriate treatment if it is required.
Thank you, Dr. Neena. Now back to Dr. Priya.
First of all, let me thank Neena for readily accepting my invitation. Special thanks, Neena. And Jayaraman sir. Jayaraman sir.
Yes, I am here.
Few words from your side.
See, I think first of all, good evening, everybody. I am very sorry that I cannot join time. I was a bit late due to I was held up in my clinic. Sorry. And I thank Dr. Praveen for inviting me for this meeting. And it was a very nice session by Dr. Neena. I congratulate both Trivandrum IAP and Dr. Neena for this wonderful session on a very important, I should say, important practice problem. We see very often a lot of pediatric ophthalmologic problem in our pediatric practice. And I think it was a very useful session for the practicing pediatricians. Thank you so much. And I wish you the very best. Thank you.
Thank you, Jairam sir. And now for a formal vote of thanks, myself, Dr. Anju K. Kanmani, Joint Secretary, IAP Trivandrum. Thanks, first of all, Dr. Neena Madam, for covering this, because we usually say the eyes will not see what the mind does not know. So right now, Madam has gone from the Corona times where the children are on in front of the digital screen through the day-to-day presentations of various conditions to the subtle signs that we usually do not see as a part of the systemic diseases and all. So thank you so much, Madam, on that comprehensive but precise and useful presentation. And formally, I would like to say thanks to all those who are present, like Dr. Jairam sir, who is the state president, Dr. Balendra sir, who has won the Best Doctor Award in our specialty, Dr. Johnny Sebastian sir for his inspiration and appreciation and support, and Dr. Narayan sir, who is the past president, for his warm regards, and of course, Dr. Santosh sir, Dr. Praveen, Dr. Sibi, and Dr. Meena, Joint Secretary. And there are many doctors, seniors, and friends present, like Dr. Bennett sir, Dr. Priya Srinivasan, Dr. Anju Divak sir, Dr. Riya sir, and of course, Dr. Sri Prasad Serena, Dr. Rekha, all were present. And of course, the SATH audiovisual segment, which was supporting us. So from us, we would like to revise all those things that we have heard today, so that we can upgrade the level of ophthalmologic management diagnosis in our regular OP as well as IP. So wish you all a great time ahead, and congratulations to all the winners, and good night from all of us. Thank you.